Okay. Hello, everybody. Welcome to the Board of Governors preparation session. My name is Kevin, put on by California Association of Healthcare Leaders and ACHE San Diego. My name is Kevin Clorty, and I'm the California Association of Healthcare Leaders Member Advancement Committee Chair, and I'll be facilitating today with some great leaders here today, our facilitators. So what we're going to do to kick it off, we've got most people in here. People are still fiddling in here, but we're going to kick it off to honor our time of everybody who's here. It's 10:02. So we're going to go to do an introduction of our first facilitator on the next slide here. So let me get the bio up. Okay, first I'm so excited to welcome Deborah Ellis, Dr. Deborah Ellis, who's from Alameda Health System. She's a system director there of quality and many other things, but she's also from a California Association of Healthcare Leaders. She's a member of the Advancement Study Group Committee and also the member of ACHE Programs, Products, and Service Committee. So I want to welcome Deborah here. She's has great background with quality improvement, and she'll be helping lead this session on quality. And then we'll move on to our next session, which is on management and leadership from Mary, who will be joining here, who's on right now, and be joining a little bit as we segue into that second part of today's sessions. Deborah, let me turn it over to you.
Okay, great. Thank you, Kevin, and good morning, everyone. And thank you for taking time out of your Saturday to be with us and your commitment for moving forward and taking the Board of Governors exam. Hopefully by the end of today's session, you will have a little bit more insight of what direction you need to go and study that you will probably need to do as part of preparation. So let's just recap some things that were shared earlier. It's what are the recommended study resources? And these that I'm sharing are things that actually worked for me. So I do have a personal story to tell there, but I found the study materials that helped and that are recommended are the Well-Managed Healthcare Organization, the Board of Governors exam flashcards. I did the ones that had digital access, and I found they worked really well for me because no matter where I was, I had my iPad. I was able to pull it up on the airplane anywhere. I would always go through a couple at a time. Sitting watching TV, it was right there. I would go through a couple of at a time. And I did go through the assessment tools, the competency assessment tools that were available on the ACH website, and a virtual study group that is put on by our local chapter, which is this one that we're in today. So one thing I had to do was understand what is the Board of Governors exam. And I found that it helped frame the approach to studying and preparing for the exam. So it's an exam that is designed to measure whether a professional has advanced from managerial execution, which is probably the space a lot of us are in right now, or was in, to strategic leadership and governance oversight. So it's not a technical or clinical certification like CPHQ or some of the others, and it's not an aptitude test like many of us took aptitude tests like LSAT, GREs, that kind of stuff, assessments for entry exams. So the key takeaway is that it measures leadership level decision making across the entire health system. And in California, there are a lot more laws and a lot more governance than in some of the other areas of the country. So that's one of the things I had to keep in mind and look for the broad overarching that would apply to everyone, not just in California. So what does it test? It tests all of these 10 domains, and they're called knowledge areas because it really is, what knowledge do you have in this area? You hear something, you don't have to be the subject matter expert on it, but you say, oh yeah, I know that deals with, and be able to move on in that way. So today I'm going to be covering quality and performance improvement. And so I think it's a very stepwise approach. Create a study structure. Dedicate time, a little bit at a time, every week, every day is what will get steady every time. Active recall and spaced repetition. Don't just read, quiz yourself repeatedly. Revisit difficult questions every few days. Learn why not. Like, why are the others the wrong choice and this one is the right choice? That kind of mirrors the exam style. And think executive level. What would you be doing as an executive when you read each question? Not in execution or carrying out, but in decision making. And if you can, do at least one full length time practice exam. I know there used to be one. I haven't looked lately, but I did take that one. And it helped me understand where my weak areas were. So on the day of the exam, how to approach the exam? Pace yourself. 230 questions, 6 hours. Don't dwell on one question, mark and return. Trust your first instincts. We hear that all the time. Look for the best answer. Eliminate distractions. Narrow down two choices before deciding and stay executive focused. Always ask, what would a senior leader do? And during the exam, read carefully, watch for qualifiers like always, never, most, least, best. Keep those in mind. And identify your negatives, those that say not all, except, to keep those in mind. Check the context of the question so you know what operational skill set or what operational area this is actually asking, and then work down from there. Take a break. Mental fatigue impacts decision making, and don't panic, especially on finance, on law. You don't need 100% in every domain. Aim for a balanced competency. So we went over there, this and how it's scored, and will be delivered, the exam format. And the nature of the exam, a lot of the questions are really scenario based in this scenario. So you have to frame it within that scenario. And then what is the question specifically asking? It will tell you the knowledge area, and then you work down from there. You look for the best response. And again, it tests executive judgment, not knowledge alone. Okay, so the quality and leadership area is 18 questions that are scored, about 9% of it. And so the domains within quality that are covered is quality improvement principles, what is governance and accountability, organizational performance data, who is CMS, Joint Commission, and regulatory standards. You don't have to know all of them, just that there are some out there that are used across all healthcare systems, and you'll hear it consistently. And quality improvement with strategic and financial objectives. What are the outcomes and how does it impact the organization? Again, knowledge area, not expertise. So with that said, let's get into the first question. And I kind of like to be interactive. However, the way my screen is set up right now, I'm not going to be able to see everyone's hands if you raise your hand, kind of thing. I'm in presentation mode, so I'm unable to see that.
I'll take care of that, Deborah's hands come up. I'll jump in, help
Thank
you out.
you very much, Kevin. So quality and performance management. First one, critical paths are important because, well, the question that's being asked here is about critical paths. So you say to yourself, what do I know about critical paths? Then you go down and you look at the answer. Critical paths provide support in malpractice suit, delineate best practice protocols, increase patient throughput, reduce resource use. What do you think that answer could be? Anyone? Okay, so we'll move ahead. The correct answer is B. So when you read the question, the first thing you ask is, what are critical paths? And it's also called clinical paths or core maps. And they're structured evidence-based multidisciplinary plans that define best sequence and timing of intervention. It actually helps standardization of best practices and reduces variability. So it is like a set standard of things that you go through. So why are the other options not correct? Anyone want to take a guess at that? Has everyone had coffee this morning?
There were some chat responses on the last one, but nothing yet in the chat room.
Okay. Okay, so let's go through. Provide support in in malpractice suit. Well, we're not demonstrating adherence to standard of care. Critical path does not designate any legal defense. So that's incorrect. So that's one that you could eliminate. Well, why is C incorrect? While efficiencies can indirectly improve throughput, that's a secondary effect, not the primary purpose. And we're asking in the question, what are critical paths and why are they important? Why are they critical? And D, reduce resources or reduce resource use. Again, this may occur as a byproduct of standardization, but it's not the primary goal. So the best answer here would be B. It is delineates best practice protocols. Keep in mind, critical paths, clinical paths, care maps, all refer to the same thing. Any questions on that one? And again, Kevin, if something comes up, please let me know because I can't see the chat.
I'm
Thank
watching.
you.
Yep.
Okay. Okay, so let's go to number 2. I'm sorry, I'm giving you the answer up front. I'm sorry. Which characteristic of high-risk process would tend to increase the risk of a process failure? What do you think the best answer would be in simplicity, consistency, variability, automation?
I'm seeing a lot of C's. C's.
C, yes, variability. Because within variability is where you get a lot of errors that happen. The more variability in a process, the less reliable it becomes. And as you know, most healthcare organizations are on this trek right now to high reliability. High reliability is all about reducing variability. You've heard things like Six Sigma and Lean. Those are all principles of high reliability to reduce variability. So the characteristic of a high-risk process that would tend to increase the risk of a process failure, what would make a process fail, a high-risk process fail? It would be variability. Not automation. That reduces human error by standardizing repetitive high-volume tasks. But variability increases process risk because it undermines standardization. Simplicity and consistency improves reliability, but variability is that thing that actually places a process at risk. Any questions on that? Or comments? It doesn't have to be questions. Okay. So next one. Which characteristic of a hot did I I gave the answer. Slide. Okay, thank you.
Yep.
In conducting a risk assessment, what would be the first action to take? Identify the step in the process of concern, identify what would fail in the process, identify causes of failure in the process, identify priorities for action.
We're seeing a lot of A's in the chat. A's are
Okay.
flying through the chat. Yep.
Wonderful, wonderful. And A is the correct answer. Would anyone like to say why A is the correct answer and the rest are not? I would love to hear from you if you don't mind.
I would think it would be different steps within that process.
Did I advance the slide already? Yeah, I'm sorry. Say that again. I'm sorry.
So I think that's like, obviously these are just different steps that could possibly be in the process. So A is obviously the first one. The other ones I just think would come after that. So I think it's just within the order. It's
Correct. You are
Yeah.
absolutely correct. You need to identify what are you fixing if you don't know what you're fixing. The way I look at it, I say, if you don't know what you're going from, and you already identify the two, you've already failed in the process. You have to have the steps and the steps. So the very first step in a risk assessment is to map out the process. You can analyze the risk or prioritize actions after that process has been mapped out. Okay,
And
thank you.
Michelle also said similarly, the rest happen after you do the initial step, which is essentially what it was stated. Thank you.
Thank you. Okay, so next question. In designing a risk management program, so we know we're talking about risk management for your organization, what approach would have the most, and that is identify a word you want to talk about, impact on reducing risk? So we're talking about a risk management program, the most impact on reducing risk. So those are the key identifiers for the question. Say, developing a report system for medical errors and injuries to staff and visitors, require assessment of high-risk areas or processes within each service department and unit, use task force to address Joint Commission standards that apply to risk management, educate staff on potential risk and patient safety.
Seen a
What's
lot of
the,
seen a lot of B's there. Seen a lot of B's in the chat.
and that would be correct. The most impactful approach to reduce organization risk is proactive assessment of high risk areas and processes. It's systematic and preventative is what you're trying to do all at the same time when you require a risk assessment on what do I need to do in reducing. So why are the others incorrect? Anyone have thoughts?
I don't have too many thoughts, but when I saw this question, I knew it wasn't C or D, so I was able to kick out. So
And
it was
why did
between
you
A
kick
or
out?
B.
So why did you kick out C or D?
Joint commit. It's a commission. It's an accreditation. It has really nothing to do. I
Yeah,
mean,
that's compliance.
yeah.
Yeah,
So
yeah.
educate staff and potential risk. That's a great thing to do. It just isn't the correct answer for this question.
Right. What are you educating on if you haven't identified? Okay. So yes, B, require assessments of high risk areas or processes. Your data and your information drives where you need to go. It tells you what needs to be done. Great. Thank you. Okay, let's move on to the next one. What action should you take to ensure that all critical activities associated with care of a patient are being carried out in the right sequence in your organization? Again, what I like to do is break down the question and it, you know, especially when the question's are long, is what action? So we're looking for an action. Should you take to ensure that all overarching big critical activities associated with care of a patient, the care of the patient is carried out in the right sequence.
We're seeing a little B in the chat right now.
Okay, institute clinical practice guidelines, develop clinical pathways, institute disease management program, develop evidence-based managed programs. And this is a great question because actually you will find things like this on the exam where you may not understand one question and it is posed in a different way or something differently later on. You can then go back and say, oh, yeah, that's what. So remember in that early question, we said that critical pathways are also called care maps or critical pathways. So yes, B is the correct answer. Notice the verbs institute, develop, that is being used to lead into the answer. And based on how the question is framed, it sounds like they're asking that you need to develop something, not institute. You institute something after it has been developed. So you need to develop it first. So that's another way you can look at things on assessing which two should I eliminate. So B is the correct answer. Any comments on that?
I love that by Kevin. Thank you for defining in the chat.
Okay, thank you. Okay, so let's go to the next one. Your medical staff on the general medicine unit has been complaining about the delays in the administration of medication. So we're talking pharmacy here. There is delay, medication delay. You study the process. How does that process work on other units? And indeed find that the general medicine unit times are considerably longer. So somewhere along the line, when you see questions like this, you say, somewhere along the line, there is a bottleneck. So on this unit, there is a bottleneck in the process. And so the question specifically asks, what would be your first step? That's an identifier right there. Your first step to take. Implement best practices from other units. Have a manager from the highest performing units assist the general medical unit in its improvement efforts. Establish benchmarks for processing times across the organization. Organize a process improvement team on the general medical unit.
We're seeing a lot of D's and maybe a C or so, mostly D's though.
Okay, so the answer is, okay, well, before I give the answer, for those that answered D, why do you think D is the correct answer?
You have to get organized first before you start doing anything else.
Okay, and thank you. And if I'm sorry if I don't call your name saying thank you, because like I said, I'm not seeing the chat, but or the gallery.
Thank you, Michelle.
Okay, thank you. So those who have said C, why did you choose C? What was the thinking on that? Establish benchmarks for processing times across the organization.
I was actually torn between C and D. I thought, one of them was definitely the right answer. But I chose C because although you have to establish a process, I'm typically used to like establishing the benchmarks first and then sort of going from there.
Okay.
To see like, what is the standard?
So thank you for that comment. So I think we agree that A and B could be eliminated. And it was a toss up between C and D. So D is the correct answer. Did you see that now? Yes, D is the correct answer. And you need to organize a process improvement team on the general med unit because the first step in quality and in improvement, this is very important. Include those doing the work. The team actually ends up identifying the process and they bring to the table questions that you may not even actually have thought about. And C could be eliminated because in establishing benchmarks for process times, it's a useful monitoring tool, but it does not address the why. Remember, I referred to the bottleneck. When you go back up to the question, you say, what would be your first step to take? And actually, it would then also be why. Why am I taking this as a first step? Is you're organizing a process improvement team on the general med unit, and probably the benchmarks are already established because you studied the process times on other units and identify that, yeah, the general med seemed like it was a longer, because we were talking about delays, than what you found in the other units. And so it seems like you could assume, and let's say not assume, but you could say that the other units were all within a tighter frame, and this other unit, the general med unit, was the outlier. So that's just thinking of it very, very broadly. Any questions on that?
There's some comments here that happened a minute or so ago. I'll just read them quickly. It allows you to engage the people who know the process best before implementing new process change, have to understand the problem, and then go into benchmarking and implementing best practices. There may be variability between units. In the book, Well-Managed HCO, they talked about pits in nearly every chapter. C can be plugged into an A3 after the team is established. So thank you, Prav and Michelle, Mr.
Thank
Lowe.
you.
Yes, and
Yes.
again, yes.
Yeah, so all great examples on how to work through the question to come up with the most correct answer. That is probably the correct answer. I think I see a hand up, Kevin.
You do, Kabiro?
Hi, good morning. Can you all hear me?
Yes.
Yes.
So, yeah. So no, I was just gonna say the question also mentioned that that the study, the processing times that the person find out that the general medical unit times are considerably longer. So I think that has been confirmed that the processing time for the general medical unit is considerably longer compared to the other units. So I think the most appropriate next step will just be to build that QI improvement team.
Yes, on the general med unit, because
Yeah.
obviously it's not the process, because the other units don't seem to be having problems in the process. It is specifically the general med unit. So what is the bottleneck that is occurring on the general med unit that is causing the delays? Really good, really good. Like that, like that. Okay. Next one. What tool, and this is where it comes in, have a general idea of what quality tools are, is most, another qualifier word, appropriate in identifying priorities for action? A flow chart, a cause and effect diagram, a Pareto chart, a run chart. So one of the ways you can look at this is you ask yourself, well, what is a flow chart and what does it tell me? What is a cause and effect diagram and what does it tell me? What is a Pareto chart and what does it tell me? And what is a run chart and what does it tell me? So knowledge of quality improvement tools, particularly these are charts and diagrams, and charts and diagrams really are only giving you a visual on presentation of the data. What is the data trying to say to you? So Kevin, do we have any answers?
We got a lot of C's here, including Pravin saying C is my go-to tool to identify and track outlier data. So everyone's going C.
Okay, so could we tell, I'm sorry, who you said there's a lot of C's, and the person that gave the explanation, could you talk a little bit more on why that is a go-to?
This is Praveen. It's and Deborah, we know each other very well from previous conversations. It is my go-to tool because it's the simplest way that I can get my staff to track something that is outside of the ordinary. And it's the one I use quite extensively. I've used it with flu vaccine clinics that we have, if there's any sort of outlier things that happen to identify risk. It's just so easy to be able to use and everybody understands it.
Right. Well, thank you. So the correct answer is C. It is the Pareto chart. And this goes into the quality principle of the 80-20 rule. Okay.
And that's exactly what Michelle put in her comment, right? 30 seconds before you said 80-20 rule. Yep.
Yes, it is that 80% of your problems often stem from 20% of causes. And a Pareto chart actually will help you in identifying what are the biggest contributors to the problem, and then it ranks down. So like recently, I could share this as my own personal experience. Well, in our organization, we've been having problems with surgical site infections. So I did a Pareto chart and found out that our intra-abdominal surgical site infections were the ones, the 80% that was contributing. So we formed a process improvement group, and we focused specifically on those procedures that were around the abdomen. We've seen a 40% reduction so far, and we're hoping to work through some others. So now that we identify 80%, it went into reducing overall our outcomes. We have less SSIs, but now I'm able to move to what is the next significant contributor. So we've added other procedures to the group because we've done a pretty good job about what was contributing 80%. So just a personal story of how I've used this recently in an ongoing process improvement project that I'm working on. And then you go back, and because you have to know the tools, you go, okay, a flow chart. What does a flow chart tell you? It tells you the steps or the sequence of a process. What does a cause effect diagram tell you? That is also called an Ishikawa diagram. It identifies all the causes. You're actually quantifying or prioritizing which ones are most significant. It's diagnostic, but not prioritizing that you actually do. And then a run chart is looking at data over time. So for my example, how did we know we had a problem? We looked at our trending first, data over time. Then we saw a shift, an uptick. We started pulling down into the Pareto chart, and boom, told us what our next step should be and what was our biggest contributor. Any questions on that? Or comments, further comments?
Interesting from Praveen saying very helpful when we engage in union dialogue. Data, yeah.
Very good. Very, very good. Actually, it's not just a performance improvement, but it actually helps frame how you read through data also. What is the data trying to tell me? And don't be fooled. Sometimes data is displayed and it's the wrong chart or the wrong diagram. Not everyone will pick up on that, but sometimes that does happen. Okay, now what approach best, a qualifier word, ensures loyalty, returned visits by patients to your organization? So we're talking about under quality improvement. Why would this be under quality improvement? It is patient engagement. And as you know or don't know, we actually monitor and track under quality what experience our patients have. And while satisfaction reflects on past experience, engagement drives future behavior. So we need to know, did we do something right? Did we do something wrong? And what could we do to correct it? So patient satisfaction survey, patient engagement, an effective complaint resolution process, customer service training.
Got a lot of B's in the chat.
We're getting a lot of B's. You guys are so smart and getting up there really right away. So it is patient engagement. So why are the other options not the correct response? Anyone want to take a stab at any of them?
I think I'll eliminate A because, you know, when you look at patient satisfaction surveys, that's just telling you, you know, the service you've already provided. It's the after effect.
Yes.
So we use NPS as our main go-to, and we analyze that data extensively to be able to identify any issues or barriers. But, you know, it starts with engaging with our patients.
Mm-hmm. And what about C?
I think outside of B, all the other answers are talking about tools to see how the patient experience has been. But the
Yeah.
only one that really engages the patient, whose loyalty is what you're after, is answer B.
Great analysis on that. C is an effective complaint resolution. You know, if a patient is doing a complaint, and you have the opportunity for what we call in the industry service recovery. Sorry, this occurred. How can I make it right? That service recovery is a complaint resolution process. And then customer service training is active participation and partnership. But B is patient engagement, is the best process or best approach to ensure loyalty return. If you ever need us again, or you need a hospital again, or a healthcare organization again, you will choose us. That's basically what it is. All right.
And a couple comments here similar to what was mentioned. Teresa, they are measurement tools, not relationship builders, is how I understand it. And Michelle, they are retrospective actions. Well, except customer service training, I guess, but still I eliminated that one first.
Okay, great insight to the approach on what can be eliminated that will bring you down to the correct answer. Great approach. Okay, so the next question. A healthcare institution would use nationally accepted clinical benchmark 2. I'm working on a clinical benchmark. It's a national benchmark. And what am I going to do with that benchmark? Determine what services the institutions should offer to meet the needs of the area. Obtain a comprehensive view of the state of the institution's business. Evaluate the outcomes of a clinical process. Oversee the clinical structure of the institution. Now we're talking clinical benchmark here. So because the test questions are all random amongst the 10 knowledge areas, how would you clue in that this is a quality and performance management question? Anyone? So the primary purpose is to evaluate and improve clinical performance. It's a measure and a comparison that you're looking at the outcomes. So what is everyone saying, Kevin?
In the chat, we've got a lot of, what do we got? C's. Yep. Not a lot of feedback on this. The word benchmark. Yeah, not a lot. C. Yeah.
Okay. So C is the correct answer. And a clinical benchmark enables an organization to measure care quality and outcomes against national norms. It's like, where do I fall in all of this? If you, and you don't have to be familiar with your 8SAG organization, but they're an organization that tracks metrics. And there are times they will send out reports and it will rank all of the hospitals within the state. And you're not able to see who the other hospitals are, but when you pull your data, you'll see an arrow and your column on your distribution diagram will show a red, and you will then be able to visualize and see very quickly, oh, here is where I rank. We're up in the upper 5 percentile. We're down in the lower 5th percentile. It evaluates and it actually shows you very quickly. So it evaluates outcomes of a clinical process. And you said, Kevin, most people actually went for C, not many else that
there
were
wasn't
chosen.
There wasn't a lot of feedback like the previous questions.
Yeah. So I think this is one of them that determine, obtain, evaluate, oversee. Those are your key verbs that you're looking into in reading the rest of the response answers. And by intuition, I guess you could say it's all about evaluating because you're looking about the clinical benchmark. Okay, I think we did really well on time. This is our last slide in question. The dual nature of quality is important for healthcare managers to understand because it evaluates not only the physician's ability to diagnose an illness correctly, but it also evaluates the physician's ability to carry out a procedure related to that diagnosis. Oof, long response. It includes both content quality and service quality. So we're looking for a dual nature. Managers not only impact administrative aspects of quality, while physicians control the patient encounter. They must work together to achieve total quality. And D, each competing aspect of quality works against the other unless clear, defined management roles are embraced. Okay, this is a long one to digest. The question is not long, but the answers are long. So I think the question is very straightforward, so we don't have to spend a lot of time. We know that we're talking about two interdependent dimensions defined in healthcare quality.
We're seeing mostly C and a B as well.
Have to spend our time, or I would spend my time, on eliminating what are the ones that are not the best that we could just eliminate. So anyone have any ideas on this? Any answers coming in, Kevin?
Yeah, it was a few C's and one B.
Okay, so those that said C, could you share on why you chose C?
I chose C because it said managers. And so I looked at C and it was very specific to managers. And so I took it pretty literal.
Okay. All right. Anyone else on C? I think something here on C on why it could be eliminated very quickly. There is a qualifier word in there. It says managers can only impact while physicians control the patient encounter. And the question actually makes, when you look at it, it's asking about technical and service, the duality of the roles, of the nature of it, the nature of quality. So you see that the best answer, the right answer was B. It includes both content quality and service quality. So in this case, the shortest answer, the most straightforward answer was the correct answer. And this goes into the quality principle of, and I think I remember it on the flashcards, the Donabedian process or the Donabedian model. It is process, outcomes, and structure. How do they all interact with each other? That is the Donabedian model. It emphasizes quality on both process and perception. And so it effective leaders integrate these dimensions through culture, accountability, and continuous improvement under the Donabedian model. But a high-level overview, it includes both content and quality, the dual nature of it. All right, that was great. So that was the 10 questions. So just a recap, test day, arrive early. What I did, I took like a 10-minute walk around the building just to clear my mind, not doing anything. When you're taking the test, remember it's 6 hours. It's plenty of time. Don't stress out. Eliminate distractor questions. Look out for all, best, most. Those are qualifier words. Read carefully. And especially those qualifier words again, always, never, most, least, best. Identify the negatives. This one is always my trip up. I always have to go back and reread the question carefully, and then I go, oh, that says not or except. I miss quite often the negative identifiers. And then check the content. If the question is strategic, the answer will not be operational. Take a break and don't panic. You don't need 100% in every domain. You need to pass the exam. And again, knowledge areas is what we're going for, not expertise. And good luck, everyone. And I will end the slideshow, stop share it, so I could see everyone on my screen. And how was that?
Great. Thank you so much, Dr. Ellis, for your presentation. And we will move on unless there's any more comments or questions before we move on.
Okay, thank you, everyone. Hopefully you got something out of the session on how to approach the exam and what you should do as part of preparing for it.
Okay, can you guys see my slides right now?
Not yet. I think it's a white screen.
Okay, wow, okay. Let me try one more time here. Let me try. For some reason, share screen, entire screen. There we go. Okay, can you see the slides now?
Yes, they're not in presentation mode, but
there we go.
Oh, now they are.
Okay.
There you go. Okay, I'm back again this weekend. So I'm going to, yes, I'm going to, Mary Lassard here. I'm going to review questions for the knowledge area of management and leadership. These are 26 questions worth 13% of the exam. So just next slide. So I'm not going to walk through this, but these are the summary of when you drill down a little bit more into management and leadership, what are the knowledge areas? And I like how Deborah said it's not expertise, it's knowledge areas. So I'm going to keep that one, Deborah. Okay, next slide. Okay, and again, more knowledge areas under this category. Next slide. Okay, our sample questions. Let's start with number 1. The purpose of a capital expenditures committee is. So my technique is I always read through all the possible answers first, and then I look to those that I can eliminate right off the bat. Hopefully I can eliminate all of them, or at least narrow it down to 2. So first response would be to oversee appointment of competent medical staff to render care for the service area. So I'm looking for a purpose of a committee that focuses on capital expenditures. So B would be to appoint an effective governing board based on the wishes of the medical staff. I'm sure the medical staff would like that response. And then C, here, to be responsible for evaluating and prioritizing requisitions for new equipment. That one's looking like a possibility, but let me read the last one. To implement stakeholder wishes on the future direction the organization should take. Okay, so I'm pretty sure I'm going to eliminate A right off the bat because it's talking about medical staff and rendering care, which the purpose of a capital expenditures committee. So there's not a relation there regarding the competency of the medical staff and the care they're rendering to capital expenditures. So I'm eliminating A. B, to appoint an effective governing board based on the wishes of the medical staff. Well, a capital expenditures committee is not going to be appointing a governing board. So regardless of what that board would do, the committee is not the one appointing a governing board. So I'm going to eliminate B. C, I really like C because it's talking about new equipment, and equipment is depending on the price of the equipment, a capital expenditure, or at least falls in that capital expenditures approval that I'm sure many of you are used to in your own organizations. And then let me just look at D to be absolutely sure that C is the one that I'm thinking of taking or answering with. To implement stakeholder wishes on the future direction of the organization. So my issue with D is that it's just so general. And what are stakeholder wishes and future direction of the organization? Well, a capital expenditures committee is not going to be implementing something for the future of the organization, you know, there as a whole. So I feel pretty confident that the answer is C. How are we? I don't have my chat up, but how are we looking as far as whether I've got consensus or if somebody thinks that it's one of the other answers? Is it looking good, Kevin? Most people agreeing with me?
Deborah's got a hand on the chat right now. Deborah?
There's C. Am I still on? Yes.
Yes.
All of the responses are C.
Yes, C. I'm going with C. So Deborah agrees with me that C is the right answer. Can Kevin, can you reveal the answer?
Yep.
And it is C. There we go. Next question. The U.S. healthcare industry is highly diverse, and to address the ongoing challenges of workforce diversity, an organization should. Okay, so let me read through my possibilities here. The organization should expand the market share by adding or enhancing services that target diverse population. Not so sure on that one. We'll come back after we read through. Develop a linkage between the marketplace and the workforce that will enhance diverse recruitment, development, and retaining of employees. I think that's a little bit closer because it talks about the workforce. C, develop a diversity education tools available both to the workforce and the community. And then the last answer is develop and implement workforce policies and management practices that maximize the talent and productivity of employees with diverse background. That is the one that I'm leaning towards. Do we have consensus? I'm going to go through and eliminate a couple of them, but that's the one I'm leaning towards. Let me just double check to make sure I'm not forgetting something or missing something. I'm going to eliminate A because it's talking about the population, and this question is talking about challenges of workforce diversity. So A doesn't talk about anything about the workforce, so I'm eliminating A. B, developing a linkage between the marketplace and the workforce that will enhance diverse recruitment development. That one, possibility, but what we're really focusing on is addressing the ongoing challenges of workforce diversity. And I'm not sure that a linkage between the marketplace and my workforce is going to really do the trick as far as enhancing diverse recruitment, development, and retention of employees, which the answer doesn't really, or the question doesn't even talk about that. And C, a diversity education tools available to both the workforce and the community. Again, the question isn't even referencing the community as a whole, so I'm going to feel pretty confident of eliminating C. And then the last one, which I think I saw some pop-ups that people are going towards, develop and implement workforce policies and management practices. Like right away, just as far as just in general, addressing ongoing challenges, that is a more of a strategic type of approach where you're talking about your policies and your management practices. And then what are those are they saying are going to do? They're going to maximize the talent and productivity of employees with diverse background. And what you're trying to address is the ongoing challenges of workforce diversity. So those policies and practices are going to target directly what the question asks or brings up as the challenge. So I'm going with D. Do we have any holdouts for any other answer?
I
No?
think the majority agrees with you.
Okay,
I
reveal.
see all D's.
The reveal is, Kevin?
D.
D.
Okay, next question.
Mary, just one
Yes.
thing. Nicole put a
Mhm.
very good comment in here. She said the issue is workforce. So the solution should be on the workforce.
Workforce. Yes,
Thank you.
thank you. Great, great articulation. I'm gonna see, yeah, there I can. Now I got my chat up so I can see these as they come in. Okay. A transformational leader adapts and applies evidence-based leadership in their practice, and the application of evidence-based practice in healthcare management is more challenging compared to the clinical practice setting because. So the question is, I was looking for a comparison and is stating that one is more challenging than the other. So let me read through my options here. The culture in healthcare management is much less professionalized, with much less formal body of knowledge and great diversity among practitioners. Okay. Is that answering the question that healthcare management is more challenging compared to clinical practice? We'll see. The B is the decision-making in healthcare management is supported by various support systems such as handbooks and guidelines, making it complicated. Okay, I don't know, a question with asking about a transformational leader. That seems a pretty narrow response for such a broad-based question. But let's move on to C and see what else we've got here on our plate as options. The difference of the context or content of the research evidence from a clinical perspective to management perspective is non-comparable. So C is basically throwing out the question altogether and saying you just can't even compare the two, which is not necessarily what the question is asking. And D, the culture in healthcare management is highly professionalized with strong formal body of knowledge. So that's D. I am going to immediately, after reading through them, throw out B and C because I think that B, as I said, is too narrow of a response, and C, it's just basically saying you can't even compare, you can't even answer the question. So now I've got it down to A and D. Now the difference between A and D, so professionalized, interpretation of professionalized meaning licensed. So when you compare the clinical practice setting, so the physicians, the nurses, RNs, LVNs, different types of therapists, often licensure is, clinical practitioners are highly professionalized. So I actually think that D might make a little bit more sense if it was flipped and it said the culture in the clinical practice setting is highly professionalized with a strong formal body of knowledge, because often, regardless, when you become a licensed professional, yes, it is very formal of what you're studying. It's very specific to get your medical degree, your nursing degree. So in healthcare management, not everybody gets to healthcare management from the same level of training. And so I am going to say A is the answer to this, because it just talks about how healthcare management is less professionalized. Well, you don't need to be licensed to be in healthcare management. And we do have a less formal body of knowledge, and there's great diversity. I mean, the people come into healthcare management from so many avenues I think that A is the best answer. Any thoughts, Kevin, Deborah,
So
before we
there's
reveal?
the response in the chat. I see just one, and it says A.
Okay.
And I'm going to put Teresa on the hot seat here. Why'd you choose A, Teresa? And it's okay to say it looked like the best answer. Oh, she said her speaker
isn't
isn't
working.
working. Oh boy. Okay.
Well,
So the answer that was put in the chat as they think A is the correct answer.
yes. Kevin, will you reveal A? Yes. Okay.
Yay.
Woo-hoo. So far, so good. Let's go on to, and I haven't reviewed these in a while, even though I do this presentation twice a year. So far, so good. An effective emergency disaster preparedness plan includes triaging arriving injured, coordinated with other community resources, and now we may not all be in emergency disaster preparedness. I know I'm in operations and I rely on those folks to be the experts. But I do need to have a general knowledge. So let's go through the answers and see what we can find. It looks like overwhelming is jumping out is B, but let's read all the options. So our effective plan would include triaging, coordinating with community resources, and hours of operation. I don't know if that would be the best answer. Let's go. B is an active command structure. I do know, and I see it all the time, whenever there is a level, orange, or what we use color codes at UCSD, where they will send across the email of whenever they've set up a command structure and what level it is for any emergency. So B is, I'm looking with B too. Payment for hospital personnel. Not high on, it's important, but it's not high on the effective disaster preparedness plan that you're going to be able to continue to pay your staff in your hospital. And then the last answer is regulatory approval from the Centers for Medicaid and Medicare, or Medicare and Medicaid Services. Again, I'm not an expert in emergency disaster preparedness plan, but it doesn't seem that in order to have a plan, you have to have regulatory approval from Medicare and Medicaid services. So I am going back to a more operational, which these answers, or the other two pieces of that plan are very operational, with the more operational answer, which is an active command structure. And it looks like we have, oh, and then somebody put here A, C, D are considerations, but they're covered by B. So basically, I like that response, that the active command structure is going to ensure hours of operation, payment of staff, and that, in line with any regulations required by CMS. So can we do our reveal, Kevin? And answer is B. Okay, great.
So there is a comment that says A, C, and D are considerations covered by B.
Yes, that's what I just went. Yes, exactly. So they kind of roll up into that. And so that would be, B would have been the best answer. And as opposed to, well, you could have those other things, but those were not, high on the list. And then again, as our participant said, covered under the command structure is going to cover those other things. Okay. Question number 5. Committees are an important management tool primarily because A, they provide a mechanism for reconciling differing opinions and facilitating decision-making. Sounds like it could be a good answer. They are the only way for providing for intra-staff communications. There's that buzzword that Deborah was talking about, and we've talked about in previous sessions about only or all, those types of words. Committees, it says they keep staff up to date on new professional developments. There are other ways committees could keep staff up, but I don't know if that's just the primarily, that word in the question that talks about important management tool primarily. So I think that staff are updated on new professional developments. They could be by a committee, but that's not the committee's primary responsibility or committees in general. And then D, they ensure self-expression and participation by staff. I think that committees can do that, but again, I'm getting back to that primarily word. And so I am going to select A.
So in the chat, oh, I'm sorry, go
yes,
ahead. In the chat, we have A, and actually Teresa said, I think D is funny.
Yeah. Well, yeah, that might be a thought held by maybe some different generations of staff that we have these days. But again, I'm focusing on that word primarily in the question, and A is it just provides a more comprehensive, higher level response. The other ones are actually more specific and narrow. And the question is not that specific or narrow, it's more broad. So again, I really like that thought process of Deborah of like, what's the context or the approach of the question, and find an answer that's within that same family kind of level of thinking. Are you down in the weeds or are you at 30,000 feet? Okay, let's go. A is the right answer. Thank you, Kevin.
Right. So Kevin
yes?
Devine or Devane, he said, I kicked out B, C, and D. So I went with A. And
yes, process of elimination is also very good technique. Even if you're not 100% confident that A is the right answer, you may have more confidence that the other answer possibilities are not the answer. So good process of elimination technique there. Okay, next question, Kevin. Which one of the following statements is in accordance with the principles of delegation? So we're really focusing on almost like a theoretical question here about a principle and delegating. So the possible answers are: the executive who subscribes to the principle of delegation knows what he or she wants to accomplish and exercises control over the work schedule of subordinates. Well, I'm not leaning towards that one, and I'll come back to tell you why. B, an executive explains how he or she wants things done and points out how the subordinate's contribution fits into the overall plan. Not leaning towards that one, and let me keep reading. A successful executive gives instructions telling the subordinates exactly, there's one of those buzzwords, how and in what sequence things should be done. Not leaning towards C either. D, in applying the principle of delegation, an executive makes relatively few decisions personally and frames orders in a broad general term. That is the response I'm leaning towards. But just to confirm, I'm going to go back and eliminate the others. So the first answer I'm not picking because it talks about control over a work schedule, very, very specific element of leadership. And here we're talking about a principle of delegation, and exercising control is, in my mind, the opposite of delegating something. So I'm eliminating A. B explains what things are to be done and points out how the subordinate's contribution. I mean, it's nice to say and point out how whatever you're delegating to someone would fit into the overall plan. I kind of like that piece, but it's the first part that is troublesome to me, where it says explains how he or she wants things done. And that is, again, not in congruence with delegation. So I'm eliminating B. C, telling subordinates, direct reports, exactly how and in what sequence you want things done. Again, counter to the principle of delegation, which is to delegate something to someone with some general guidance and support and how you would like something accomplished by a member of your team. And when they're doing that, when they're doing whatever you're delegating to them, those decisions are going to be made by the person who you delegated it to. So D is not in alignment again with the principles of delegation. So excuse me, D is in line with the principles of delegation because you're delegating the act or the task to someone. So I'm going with D. And we have Teresa's added a nice, it's about empowering others to make decisions and take responsibility within specific boundaries. Yes, general terms, instead of the leader personally controlling every detail. Exactly. So can we have the final reveal, Kevin, before we move on? And I think based on the responses, and thank you for those responding in the chat, it's nice to get that participation, and D is the correct answer.
Right.
Okay.
And
Yes.
Teresa, this is the one that says about empowering others to make decisions and take responsibility. Is that this one? Yes. Within specific boundaries, instead of as the leader personally controlling every detail. I think in the jargon of leadership, it's called micromanagement.
Yes. Thank you, Deborah. Okay. Let's go on to question 7. Oh, a very short question and short answers, but that doesn't always mean they're going to be easy. So let's see what this one entails. Which of the following is not an executive office function? So right away, you got to pay close attention to the question, because it's if you miss that word not, you could inadvertently give the wrong answer. So we're looking for executive office functions. So let me see here the executive office function: control, lead, support, or represent. Automatically, I'm going to eliminate A because executive office very high level, and they're not in the weeds controlling every decision or process. B, lead. Well, I think executives, that's something that they do. So that is something that they do. So then it would not be the answer for, I'm sorry, I'm getting mixed up here, would not be the answer. So we're looking for executive functions, an answer that is not an executive function. So A is what I'm leaning towards, but let's just look at B, C, and D. And I think that leading, supporting, and representing are all executive functions. So therefore, I'm going to go with A as the answer that is not an executive function. How does it go? A. There you go. Perfect. Represent. Somebody said A. Kevin said A or D, and I was thinking of maybe Deborah or Kevin, other people that think of examples where the executive office represents, is representative. I can think of maybe representing the organization in the community.
Right.
So I don't know if there's other examples where you would think an executive office function includes represent representation or representing.
Yeah, I can't think.
One I think of also is representing the internal operations to the board.
Yes.
Thank
It
you,
is.
Rick.
It is the executive function, as Richard said, to represent the organization to the board. But when you look at the structure of an organization, when you set the mission, the goal, the aim, it is the executive leader that then sets the tone of the culture of the organization. And so I mentioned before, what's not an executive office function? Control, micromanagement. I believe it was Lee Iacocca that said, always tell your team the what, the when, the where, the why. Let them surprise you with the how. And control always gets down into the how, which then leads into the micromanagement. So you stay framed on what needs to be done, why it needs to be done. If there is a deadline, you then, with those aspects of things, empower your team through your delegation.
Great. Great comments, Deborah. Really appreciate that. Next question, 8. What is the correct order of stages for accomplishing organizational change? Order questions. They seem pretty straightforward, but sometimes they can be a little bit confusing. So let's see what we're looking for: organizational change. So what do we start with? Organizational change. Do we start with identifying, planning, evaluating, or planning? So B and D start with the same thing. So I'm going to put those aside just for now and look at A and C. So do we start organizational change with identifying, planning, implementing, and evaluating? That I'm leaning towards that one. That one sounds pretty good, but let me come down here. C, evaluating, planning, implementing, and identifying. Well, if you've to start off with organizational change with evaluating, maybe you might kind of think, start thinking of, well, we may be evaluating what we want to change. But at the end, the last piece of it, of the last part of the phases or stages, is identifying. And I don't think of identifying as the final stage of organizational change. So I am going to eliminate C. Now I'm going to look at B and D and compare them, planning, identifying, or planning and evaluating. Would you plan before you identify the change that you want to make? Not in my experience. So I'm going to eliminate B just on the first two order of the stages for organizational change. And then D, planning, evaluating, identifying, and implementing. Again, planning before you identify what change you want to make, and then evaluating before you've implemented something. If you're ever been, I don't know, some organizations might use the Plan, Do, Study, Act cycle, and it's very common in organizational change. And so when you think of that, you have the identifying of what you want to start off with, and then the planning and the implementing is the do, the studying is the evaluating, and then you kind of get back to acting or course corrections. So I'm going with A. Identify, start with, and close with evaluation. Yes. And then Teresa also said, this one is challenging in my opinion because of looking for the key word in the question, correct order. All of them are part of a process. So looking at what you must do first was key for me, which is identifying. I agree, Teresa, very, very much so. Any other thoughts or questions before we identify the correct answer?
I'll make a comment, Mary, and to that point that Teresa just made, know that in the examination, if there is a question that you think could improve on the phrasing of the question, you have the opportunity to give that feedback on that question. So this one says, what is the correct order of stages for accomplishing an organizational change? And as Teresa pointed out, the limiter or the identifier is what is the correct order. So maybe if this question had in it from start to finish would be more of a qualifier than a broad overarching that way. So good point, Teresa, very good point.
Yes. Okay, let's go to the next question. Oh,
we didn't reveal.
Yes,
okay.
Yes, A. Very good. I think we're all convinced it was A anyway. Okay, 9. In the healthcare field, the accountability of management is best measured by. So our question is focusing on management accountability, and we're looking for the best. So there may be answers that are true, but we are looking for the best answer. So keep that mindset as we're reading through these possible answers. Balance maintained between service quality and operational efficiency. That one maybe. Let's go into B. Results shown on the annual expense and income statement. Would that be the best measure of accountability? Just an income statement? I'm not leaning towards that one off the bat. Balance maintained between physician satisfaction and patient needs. Management accountability. Well, let's see. Let's read the last option. Degree to which management's needs are met. Well, as I get to the bottom, I'm going to say that D is eliminated because accountability of management is not necessarily ensuring that their needs are met. That would be, in my opinion, the opposite of being held accountable to a broader mission or value. So I'm going to eliminate D, and then I'm going to go back up to A, B, and C. And again, I'm focusing on that word best. So when I look at B, it looks too narrow to me to be the best measure. Finances are a good way of looking at accountability of management. Are they, financially managing the organization in a responsible or accountable manner? Yes, but is that the best measure for accountability of our management leaders? The fact of C, balance between physician satisfaction and patient needs. I mean, I do think that those are things that management is held accountable to patient satisfaction, physician satisfaction, but I don't think that that's the best measure of accountability. I think that B and C are also rolled up under, as we had talked about in another previous question, about the balance between service quality and operational efficiency. So, that's where the management is making sure that their goal is to provide, highest service quality or quality of service, whether that be, patient satisfaction, quality of care delivered, and then doing that in an operational and efficient, cost-effective manner. So I think when you look at that broader scope of the answer for A and balancing those two, because, you can be so operationally efficient that you cut corners and service starts to suffer, and then vice versa. You could just be focusing so much on quality and not keeping your operational efficiency, and then you've blown your budget and you're in the red. So I'm going with A. And Teresa agrees, and Kevin's revealed, and there we go. So again, this is focusing on that word best. Okay, got a few more minutes here, so let me try and get to, I think this is the last question. The cultural climate of an organization affects its recruiting procedure because A, it reduces employee turnover and absenteeism. Well, that's if the cultural climate is good. So I'm not, or the cultural climate could be bad. But so I'm not thinking that A is the best, but let me read the others. Organizations seek applicants with attitudes, values, and goals that are consistent with those of the organization, possibly. Applicants who cannot support a given culture will be unwilling to work for that organization. That could be true. And usually when you are an applicant and looking for somewhere to work, organizational culture that is aligns with, your own values is very important because it can be very hard to work in an organization that is not aligned with your values. So I think C most likely is not the answer. D, applicants look only to organizations that portray a positive cultural climate. Well, the word only is where I'm gonna eliminate that because there are many reasons why applicants apply to organizations. Yes, positive culture can be up there on the list of why people want to work for an organization, but that word only seems to me to disqualify D as the answer. So I'm looking at B as the most likely response that will answer the question as far as affecting the recruiting procedure or process. I don't know, procedure is a weird name here. A weird word to use in my opinion for the question. But and then I think A, I didn't like it in the beginning, but I'm definitely gonna eliminate mainly because it's just so narrowly focused. It's only stating that your cultural climate, whether that's good or bad, would reduce employee turnover and absenteeism. If you have a great culture, that would reduce employee turnover and absenteeism. But if your cultural climate is toxic, then it's not going to do that. It's going to increase that. So that I don't like A for that reason. So B, and I see B's consensus. Kevin, do you want to respond to the answer or tell us what the answer is? B. I do want to point out, and I know Rick might have some comments because I know we've talked about this. Applicants who, align or consistent with the organization. I know we've had thoughts about, well, sometimes it's good to have diversity of thought within your organization. And if you only hire for everyone who thinks and is completely aligned to everything the organization does, may hurt the organization in the long run. I think that this B is general, as far as attitudes, values, and goals. But any thoughts on this, Rick?
Yeah, no, you said it well. It's what I've said before, just a little bit stronger, is that this is what we have to battle with any kind of diversity program, is that we say we want diversity, but we keep hiring ourselves over and over.
Yeah.
And diversity of thought too.
So diversity in always.
Yes.
Yep.
Okay. I think that's the last question. Is there one more? Nope. That's it. And we're at 11:29. Well, not a minute too soon for our 11:30 timeline there. Any last questions, thoughts, comments before we wrap up today's session?
I will say one thing since there's no other thoughts from the audience. Well, first of all, thank you for Dr. Deborah Ellis for her presentation and being part of this team, as well as for Mary presenting once again, as she does for many times in the past and even through these sessions. And the last thing I'll also say, we're going into week 5 next week, so to the final stretch of this, and looking forward to you got your possibility to grow to the fellow FACHE. And if for those who have not already signed or are already going, Wednesday is CAHL Congress in Sacramento, and what you need is in-person credits, and they're available if you come to CAHL Congress in Sacramento. So hope to see a few of you there, if not everybody. And if not, we'll see you next week. 6 credits. Yes, that's in the chat. 6 credits, and you'll be there, Ryan and others. So we'll see you there at CAHL Congress. Say hi to me or others, and see you next week. Take care. Bye-bye.
Thank you, everyone.